everybody. Thank you for joining us this afternoon. And thank you to Unite for Sight. I think this is a very exciting forum for us to kind of deep dive on the complexity and the diversity of global health. And my contribution here today is really to help for those of us who've been in global health to kind of remind us about some other lenses of looking at global health delivery. And for the hosts of us who are just coming into the field, welcome. And to kind of give you an introduction to a different lens of looking at global health. So this is a good way to start. I think that it's safe to say that most of us who come into global health already know that we are kind of defined in terms of the diseases we work on, the sectors that we work in, and that tends to be really HIV, AIDS, TB, and malaria. So much so that I think it's safe to say that even outside where we are, everybody tends to think that we really just are about HIV, AIDS, TB, and malaria. But are we really? I think it's good to say that we're not. It's a complex field, it's a diverse field. And that's why it's good to always use this as a backdrop of what else is going on in global health that needs to be talked about, that needs to be brought into the discourse. And neglected tropical diseases are very much within that framework. This slide is just basically for us to see and to demonstrate where neglected tropical diseases lie in terms of the disability-adjusted life years. And I don't need to reiterate, we are smack in the middle right there. So what are these neglected tropical diseases that we have now started to call NTDs? They're a group of, depending on who you talk to, 17 to 19 parasitic and bacterial infections. They're the most common infections of the poor who are living primarily in Africa, Latin America, and Asia. They're conditions that have been among us for centuries, and their conditions, like I said, are going to be affecting the populations living in rural areas in Africa. These are subsistence farmers or people living in urban slums. But because we're talking about such a long list of diseases, there has to be some common themes to link these diseases so that we can have this cluster that we call NTDs. Two of these things that I'd like to highlight is, one, these are not typically diseases that kill. These are diseases that cause morbidity. And as a result of the morbidity that they cause, they're directly related to poverty. So we really are talking about diseases of poverty. And for those of us who don't have a good understanding of this 19 list, I think it's just a good idea to just give a little image, so to speak. This is a young girl who's suffering from intestinal worms, robbing her of nutrients, stunting her growth. A lady who's suffering the severe consequences of lymphatic filariasis, a filarial worm that is transmitted by mosquitoes. And an image that I think most of us might already be familiar with, a man who had suffered the devastating consequences of river blindness. And this is a good image for us to kind of understand the next couple of slides that I'll be going through. Because I think it tells a story, and we can assume just by looking at the image that this is an old man and his grandson trying to find his way around the village or the community, or it could very well be just a member of the community who needs to find his way around and is relying on this young child to get him around. But I think it also speaks very much to the point that I made earlier, that NTDs are directly linked to poverty because of the morbidity that they cause. And the poverty that we're talking about is among these 1.4 billion people who the World Bank describes as living on less than $1.25 a day, what we term the bottom billion. And again, generations upon generations who are continuously living in this cycle of poverty. So, as I mentioned before, there is a vast distribution of NTDs across the world. And because we're talking about a list of 17 to 19 diseases, the good or bad news is that there are 7 of these that are the most common. And these are the 7 that occur in one individual at the same time. So this graph is just showing, kind of demonstrating how many individuals around the world have more than 5 NTDs at the same time. And you can see that the majority actually have 7 of the NTDs at the same time, particularly in sub-Saharan Africa. Good news, there is a solution. The 7 most common do have available drugs which are donated from pharmaceutical companies, GSK, Pfizer, and Merck, something that we call the rapid impact package, so that if these drugs are put in one package, they can be given to the individual at the exact same time. And then there's even better news. Because we put these drugs in a packet, we can bring the cost down to as little as 50 cents per person per year. And the cost is covering delivery, equipment, the training that's involved, the monitoring, and the evaluation that's involved as well. So there are several approaches to control and elimination of NTDs. I highlight a few of them here. Community-directed interventions is a very critical component of NTD control and elimination, and it's what I'm going to be covering in the next slide, so I won't go too much into it just yet. But I'd also like to just mention very briefly the other two strategies. Vector control. Like I said before, these are infections that are often transmitted by the simple bites of a fly or a mosquito vector that's also responsible for malaria transmission. So looking at control strategies that are focused on vector control is something that is an approach towards NTD control and elimination. The other aspect is infrastructure change. NTDs are intricately linked with water and sanitation, for example. Until we have 100% water and sanitation coverage around the globe, we're pretty much not going to get rid of intestinal worms. And that's why it's important that when we think about the long-term impact and how to actually eliminate NTDs, we think about the infrastructure change that's going to happen. Coming back to my first point about community-directed interventions. I'm originally from Kenya, and I remember as a child, every time I got a cold, the first person I called on was my mother. And she would burst into the room, and then there would be a whole process of slathering my body with Vicks from my back to my throat to my nose. It's an uncomfortable process for those of you who've been slathered with Vicks. But in the end, you find yourself consistently calling on your mother to come and slather you with Vicks every time you have a cold. The other incident that is very fresh in my mind, because I was a very energetic child, is swallowing a coin. Unfortunately, my father wasn't there to rush us to the hospital. And all I remember is my mother scooping me up, running out the house to my neighbor's house to see if there was anybody home to take us to the hospital. And I think this clearly demonstrates how health is ingrained and belongs within the family structure, but more so belongs within the community structure. And the community takes care of each other. There would rarely be an opportunity where a neighbor would say, no, I can't take you, I'm a little bit tired. Those situations hardly ever happened. And that's why I think that giving the community the ownership over their health really does bring to us 2 or 3 things that I'd like to highlight. One is empowering the community so that they know what's important for themselves, what's important to prevent infections. 2, it's a sustainable process. We're talking about people who are willing to help, whether or not there's a financial component attached to it. And 3, and most important, is it brings us closer to getting the drugs to people's mouths. So just to give us a little bit of a flavor of how the NTD community has used the communities in NTD control and elimination, I thought just to give us a couple of case studies that you might all be familiar with or may not. The first one is the African Program for Onchocerciasis Control. And because we are based in Washington, D.C., and everything is an acronym, APOC. APOC was established in 1995, and it was birthed from the Onchocerciasis Control Program, which was looking at vector control in 30 countries. I may not have mentioned, but Onchocerciasis, or river blindness, is spread by the simple bite of a small black fly. And so there have been a lot of control activities focused on controlling the black fly. APOC, birthed from the initial program, was looking at a new strategy, looking at vector control, combined with providing ivermectin, which has been donated and continues to be donated by Merck Pharmaceuticals. And the backbone of APOC was to get communities to treat themselves, to take ownership of the river blindness programs. So they'd go into communities, select volunteers who would then be trained by the district health officials or the Ministry of Health officials, who would then be provided with the drugs and the education materials and would be responsible for providing ivermectin to the communities. And what has happened since then? We have more than 500,000 community drug distributors who've been trained. And these graphs are unfortunately a little bit outdated. New data is showing that about 65 million people in 19 countries are getting regular ivermectin treatment through the APOC program. The other piece of good news with the APOC program is that they've started to expand it to include other interventions, vitamin A, deworming, you name it. And this is a good graph just to show you what else are these communities getting just from this one community drug distributor. I think the case in Nigeria is particularly interesting. Everybody's getting vitamin A, they are getting primary eye care help, they'll have trachoma surgeries or trachoma surgery referrals if it's possible. The other case study that I like to bring up is Burundi. Burundi has, for a very long time, had a significant issue with intestinal worms and schistosomiasis, but unfortunately they were unable to scale up their program to reach national scale. In the last 4 years, in partnership with the Ministry of Health and local NGOs and donors, we're talking about more than 18 million treatments for intestinal worms and schistosomiasis that are being delivered through community drug distributors and through social workers as well as school teachers. Similarly, in Rwanda, where intestinal worms used to be the second most common ailment reported in health districts, second only to malaria. And yet there were no national scale programs to provide deworming pills which were being provided for free to these populations. Again, through the partnership with the Ministry of Health, local NGOs and donors, more than 17,000 people have been trained to provide these in a systematic and coordinated manner. What I like the case about Rwanda is because ever since the genocide, this is one of the health programs that has actually reached national scale and is actually a strong enough program to which we can start to think of building other interventions. Not to be outdone is another case study in Lao People's Democratic Republic, where again we've seen a strong partnership between the Ministry of Health and the Ministry of Education to use the school teachers and students to educate populations about the importance of deworming, the importance of coming for the free deworming that is going to be provided at the schools. And what I think is important about Lao is, as you can see in the graph, the school students, the school-age children are getting treatment. But there's an added component, something that other programs might be struggling with, reaching preschool populations. In just 2 years, Laos is reporting that they've reached about 100% of preschool-age children who need deworming treatment. So what does it matter that we have this success, these pockets of success all over the world? What does it matter that we have 500,000 community drug distributors trained in sub-Saharan Africa? I think that this is an important and a critical juncture to kind of think about how do we make this the next step? We know that there are gaps in health system strengthening. We know that we have this resource. So what do we do with it? And there are two things that I like to throw out to the audience, or rather to reiterate, because I think that these are not necessarily innovative ideas, but there are things that we need to think about exploring further. One is, how do we legitimize and institutionalize these community health workers? How do we make them a critical component of the health system? Is this including curriculum in universities so that community health workers are actually professionals that can be compensated? And I think it's an idea that's worth exploring a little further, just so we think about, while we are thinking about health system strengthening, which is beyond just bricks and mortar. The second thing is, how do we further integrate what community health workers provide to populations? We have community health volunteers who are working in NTDs, in malaria, in microfinance. How do we bring all these together so that you're having one package, a very strong package that's looking at providing the resources to the community? So I'm speaking to you because I come from the Global Network of Neglected Tropical Diseases, an advocacy and resource mobilization initiative based at Sabin Vaccine Institute. Our work at Global Network is to explore neglected tropical diseases and basically look at how do we take them to national scale, how do we take them to global scale. We work with technical partners, we work with World Health Organization and Ministries of Health, we work with private donors. We want to mobilize resources to bring these programs to scale, but we're also looking for new ideas and new partnerships. How do we combine our efforts with the efforts in other disease-specific interventions, or how else can we look at cross-sectoral collaborations? So if you're interested in learning a little bit more about what we do, please feel free to go to our website. We do have a lot of resources there, but I also look forward to some of your comments and suggestions at the end of this session. Thank you.